When a patient passes out in the ED, the question isn't just why did they faint? It's is this someone I can safely send home or someone who could die if I miss something? Because most syncope is benign, but the dangerous causes, they're easy to miss and they carry real consequences. And having a simple framework can help you make that decision in seconds. Hi, I'm Dr. Emily F., and in this episode of Teach Me Something New in Under 5 Minutes, I'll walk you through how to approach syncope in the ED. Syncope is one of the most common complaints that we see, and also one of the most frustrating. Because by the time the patient gets to you, they usually look completely fine. Their vitals are normal, the exam is normal, and most of us were taught different scoring systems like San Francisco or Canadian syncope rules. And while they're helpful, what you really want to know is this syncope benign? Is this cardiac? And do I need to admit this patient? So that's where a simple approach comes in. Instead of memorizing multiple rules, think in 3 steps. First, confirm that this is actually syncope, a true loss of consciousness with rapid recovery, not a seizure, not intoxication, and not hypoglycemia. Before anything else, don't miss the basics. Every syncope patient gets an ECG, there's no exceptions for this one, a point of care glucose, and a pregnancy test if applicable. The ECG is your single most important test. It can immediately identify life-threatening causes. Hypoglycemia can mimic syncope entirely, and a positive pregnancy test changes your differential instantly because now you're thinking ectopic pregnancy or hemorrhage. Second, look for red flags. This is the most important step and requires a detailed history. Ask yourself, did this happen during exertion? Was there no warning or prodrome? Did they have palpitations beforehand? Do they have known heart disease? Then interpret the ECG. I like to use the ABCDE left right rule as a quick high yield screen for dangerous pathology. So, A, is there a high grade AB block? B, any signs of Brugada syndrome? C, is the QTC prolonged? D, is there a delta wave suggesting Wolff Parkinson White syndrome? E, do you see an epsilon wave that's concerning for ARVD? Then think structurally. Left, is there LVH suggesting pathology like HOCM or aortic stenosis? Right, is there RV strain patterns suggesting a pulmonary embolism? If any of these are present, that's not a routine syncope patient. That's someone that you need to worry about. And then third, risk stratify. If the story is classic vasovagal with a clear trigger and prodrome and the ECG is normal, that's low risk. But if there's no prodrome, there's any abnormalities on their ECG, or there's concerning history, that's high risk. So what makes syncope tricky is that the dangerous causes are often transient. The patient may look completely fine, but the underlying issue could still be an arrhythmia, aortic stenosis, pulmonary embolism, or even an ectopic pregnancy. And for some patients, syncope is the only warning sign you get before sudden cardiac death. So this isn't about diagnosing everything. It's about not missing the high-risk patients. So this is how it plays out in real life. A patient comes in after passing out, and now they feel fine. You quickly run through your framework. Was there a prodrome? Was it exertional? Were there any palpitations? You check the ECG, the point of care glucose, and when appropriate, a pregnancy test, and then you make your decision. If this looks like vasovagal syncope, they can likely go home. But if it's unexplained, there's no prodrome, or the ECG is abnormal, that patient needs monitoring, further workup, and possibly admission. A simple way to frame it is unexplained syncope plus an abnormal ECG, that's not a discharge. So just to wrap it up, most syncope is benign, but cardiac syncope is the one that kills. The ECG is your most important test. And don't forget the basics. Glucose and pregnancy testing can change everything early. The key idea is simple. No prodrome, abnormal ECG, or concerning history, think high risk. Because at the end of the day, syncope isn't about figuring out every cause. It's about answering the question that we actually care about in the ED. Is this patient safe to go home or not?